Assalamu alaikum. I hope so. You all are fine. So today I am back with Dr. Naghman
Hello.
Zuberi. He will give another lecture conclusion. It's yes, sir. Assalamu alaikum, sir. How are you?
Alhamdulillah, I'm good. Walaikum assalam. I think there is a problem with your voice. It's not clear. It is fading away and then it's coming back.
Yes, sir. I have like electricity problem here, so I am
Okay.
using mobile data. Sir, you
Okay.
can start your lecture.
Okay, I'm starting now.
Yes.
Okay, guys. So this is the part two of the etiology of malocclusion. And as you proceed with some topic, then you find that, okay, some more explanation, some more discussion would be required. So we are actually extending it to the part three as well, which we will be doing on 19th of October. So let's start where we were and where we finished last time, and then I told you that we will continue from there. I told you about the development of the systems of classification, like researchers Andrews, Roth, Ashen Ramford, and Rinchus. They all introduced the functional concept of occlusion, which challenged experience based rather than evidence based concepts, which were like the evidence based, experience based concepts they were proposed by Edward Engel. And he proposed that the on the basis of the relationship of upper and lower first molars, so he classified the malocclusions. Well, over the period of time, several classification methods have been proposed to categorize the etiology of malocclusion. And when we discuss about the systems of classification of etiology, so the inherited, those are the predetermined or genetic. These are the factors. And the acquired factors or the environmental factors. McCoy and Shepard in 1956, they just broadly classified into two groups: the direct factors or determining factors and indirect factors, which were the predisposing factors. In 1972, Robert Moyers, he classified as heredity, developmental defects, trauma, physical agents, habits, diseases, and malnutrition. So he classified in the under the heading of heredity neuromuscular factors, bone, supporting bone, as well as the bone of the jaw, teeth, soft tissues. All these factors, they are actually under the influence of heredity. Mostly they are from the inheritance. A person inherits from their biological parents all these things, and they influence the development of occlusion. Then comes the trauma. It could be prenatal or birth injuries, or trauma postnatally. It could be a fracture of the jaw, or it could be trauma to the teeth, like uh, Evel's tooth or intruded tooth or something like that. So both type of traumas, they also influence the development of occlusion. Then comes the physical agents. Say, for instance, there are carious teeth and they were not being treated at the proper time, or they had to be extracted prematurely, or they are lost prematurely, as well as patients, like a person's diet. It also affects, because when a child is growing, they need certain nutrients and for proper growth, and they need some vitamins. So a diet which is deficient in vitamins or other minerals and nutrients, that also affect the development of occlusion. Then comes habits. Thumb sucking and digit sucking, it is the commonest habit we will see among the children from like couple of months old up to like 4 or 5 years common, and then if it is persistent, then definitely it is going to affect the development of occlusion. Tongue thrusting was considered previously as one of the reasons for open bite, but later they found out, last 15-20 years, they found out that actually tongue thrusting is a sequelae to the open bite. It is not the uh, reason for the open bite. Then some children, they have lip sucking, lip biting, even like they have nail biting and all other habits. Then posture plays a very vital role in the whole development of the skeleton, including the occlusion. Then certain diseases, they could be systemic diseases, could be any type of systemic diseases like rickets or maybe osteomalacia or whatever, like vitamin D deficiencies and certain things which are going to affect the general physiology of the person, as well as endocrine diseases. Then the local problems like nasopharyngeal diseases, obstructed respiratory system and disturbed respiratory function, uh, recurrent nasal and upper respiratory tract infections. The person becomes oral breather instead of nasal breather. And not in all the cases the malocclusion is going to be developed, but in some of the cases, it also affects the developing occlusion. Then gingival and periodontal diseases, and certain cases in certain children, because of some underlying systemic problems, the periodontal problems also prevail. They are dependent on the systemic problem, and they also affect the developing dentition. I have already mentioned about the caries. When there are caries, then especially the proximal caries, then there are like spaces available in teeth, they tend to move mesially. So if they are not being restored at the proper time, there would be definitely disturbance in the developing occlusion. Certain tumors and certain cysts, they also uh, displace the teeth, and they are also going to affect the developing occlusion. Then other factors I have already mentioned about the malnutrition as well as the developmental defects of some unknown origin. So that's how Robert Moyers, he classified the etiology of malocclusion in the year 1972. Then came the White and Gardner's classification, and they broadly classified under the heading of dental base abnormalities, then pre-eruption abnormalities, as well as post-eruption abnormalities. So dental base abnormalities, antero-posterior malrelationship, like class 2, class 3 malocclusions. Vertical malrelationship means open bite, deep bite. Then the lateral malrelationship, which could be posterior cross bites. It could be lingual cross bite, it could be buccal cross bite, it could be a scissors bite, etc., etc. Then disproportion of the size between teeth and basal bone, crowding or the spacing problems. And then certain congenital abnormalities like maybe cleft lip, cleft palate, or some other problems. So they also influence the occlusion. Then pre-eruption abnormalities, those are the abnormalities in the position of developing tooth germ. It is not present at the right place. Or maybe agenesis of certain teeth, most commonly mandibular second premolars. And then maxillary lateral incisors. We are talking about the permanent teeth. Then the supernumerary teeth and teeth which are in abnormal form may be a pack-shaped lateral incisor and mesiodens, they are present. So their presence also, or if the teeth are not properly formed, the pack-shaped lateral incisors, definitely they will affect the developing occlusion. Large labial freedom. Well, this is again nowadays, like previously in the till 1990s, when they were seeing that any labial frenum which is very large and there is a diastema, so all the orthodontists, they were referring those patients to the oral surgeons, and a lot of frenectomies were being done. But in the last couple of years, maybe 20 years, then a new concept developed, and now most of the orthodontists, they are of the consensus that firstly treat the diastema. And if still you feel that the labial frenum is going to cause the uh, relapse of the situation, then you have to go for the uh, frenectomy or frenoplasty actually. Then comes the traumatic injury. It could be trauma to the jaws, it could be trauma to the teeth. Then the post eruption abnormalities. They are classified under the heading of muscular problems, premature loss of deciduous teeth, and extraction of permanent teeth. So, muscular, like active muscle force, thumb sucking, and hyperactive mentalis muscle, and all those they affect. Another thing is the rest position of the musculature. Keep in mind, very important point, which I would like to tell you, that uh, teeth, they always stay in the neutral zone. Means where there will be neutral effect from the tongue as well as from the lips or the circumoral oral musculature. So that is going to, where the force coming from here, force coming from the here, it will be equal. Teeth are going to accommodate themselves in the neutral zone. So that is also one of the effect which will be causing malocclusion to develop if there is very hyperactive mentalis muscle. So maybe you will see that it is going to affect the lower arch form, and if there is no proper lip seal, so you will see procline incisors, etc., etc. Let me just get my pointer back. So rest position of the musculature, then sucking habits, abnormalities in the path of closure. Then comes the premature loss of deciduous teeth. Most commonly, the deciduous molars, when they are lost, they affect the arch length. And like if the situation is not tackled at the appropriate time and the space maintainers are not placed, then the loss in the arch length will be there. And definitely it is going to create problem in future when the permanent teeth, they are going to erupt. So there won't be adequate space to accommodate those. Similarly, extraction of the permanent teeth, especially the most common tooth which is lost at an early age, is first permanent molar, and that is most commonly mandibular. So when the mandibular second molar, it erupts in a more mesial position, and with the passage of time, it tilts and tips mesially. Similarly, the second premolar, not too much, but definitely it also migrates a little bit distally. So that situation, and then upper tooth, if it is present, it also starts over erupting. So that also affects the development of malocclusion. Well, in like later Prophet, he also classified the malocclusion, but under the three headings only: the specific causes, genetic influences, and the environmental influences. Specific causes: disturbances in embryologic development, skeletal growth disturbances like fetal molding and birth injuries, birth trauma to the mandible. It is not very common nowadays, but like maybe 2 or 3 decades ago, it was quite common. Then childhood fracture of the jaw, because children, they are involved in sport activities, or maybe otherwise they get the jaw injuries, and which may lead to ankylosis of the TMJ and all those problems. So whenever there will be ankylosis of the TMJ, that is also going to affect the developing occlusion. Then muscular dysfunction, acromegaly and hemimandibular hypertrophy or hyperplasia, unilateral, on only on one side. Then disturbances in the dental development, maybe congenitally missing teeth, malformed teeth, which I have already mentioned, like the lateral incisors, which are not having the proper uh, morphology, supernumerary teeth, interferences with the eruption, ectopic eruption, early loss of the primary teeth, and traumatic displacement of the. At times, what happens, the trauma occurs and tooth is intruded. Then you have to see whether the intruded tooth is going to affect the developing tooth or not. If it is not, then we are not bothered about it. But if you see that it is going to affect the eruption of permanent tooth, then we have to tackle with the situation. Then the genetic influences. True skeletal class 2, true skeletal class 3. Most commonly, skeletal class 3, it has more genetic influence, and the tooth size, jaw size discrepancies, they also genetically influenced. Environmental influences, functional influences on the dentofacial development, then masticatory functions, sucking and other habits, then the tongue thrusting. As I told you previously, it was considered that it is going to cause the, or it is a causative agent or reason for the anterior open bite. Then the respiratory pattern. Well, at times, missing teeth also, like say, for instance, lower first permanent molar is missing at an early age. So the tongue, it also starts thrusting in that area, and it affects the second premolar, that is also being pushed slightly buccally, and then it is going to cause the trauma from occlusion because of the off-axial forces, which are going to be, we can discuss that in a separate lecture about the trauma from occlusion and how it affects the dentition and what would be the problems. Graeber, he classified under the two main categories, general factors and the local factors. General factors, he also named those as extrinsic factors, the hereditary, which is the inherited things. You, like a person is getting it from their parents, from their biological grandparents, etc., etc. Then the congenital defects, cleft palate, etc., cleidocranial dysostosis, cerebral palsy, syphilis. These also affect, or they contribute towards the development of the occlusion, like the developing occlusion, the problems in which which are occurring in that. So congenital defects, they play a very vital role. Then the environmental factors, prenatal trauma, maternal diet, maternal metabolism, German measles. Then the post, like German measles, mother gets when she was pregnant. Then the postnatal problems, birth injury, cerebral palsy, TMJ injury, etc., etc. Then the predisposing metabolic, climate, and disease, like endocrinal imbalance. It could be growth hormone deficiency. It could be thyroid hormone excess or deficiency, etc., etc. Then the metabolic disturbances, infectious disease. Metabolic disturbances are so many, and even the juvenile diabetes, it also one of the metabolic disturbances. Then infectious diseases like poliomyelitis, etc. It is definitely not very common nowadays, but it was once a very major reason of having these skeletal deformities. Then the dietary problems, nutritional deficiency, abnormal pressure habits, abnormal suckling, forward mandibular posture because of that, non-physiologic nursing, excessive buccal pressures, thumb and finger sucking. Tongue thrust and tongue sucking, we have already discussed that. Now we have a different concept, but previously it was considered as one of the major reasons of anterior open bite. Lip and nail biting, then abnormal swallowing habits, speech defects, respiratory abnormalities, mouth breathing. But keep in mind that respiratory problems or mouth breathing, they are not going to affect each and every single individual who is having mouth breathing problems or adenoids or something like that. Case to case, yes, there is very typical long face appearance, and we consider, if like we see those people, we have this thing in our mind, yes, there would be some respiratory problem during the developing phase, or when the child was developing or growing. Tonsils and adenoids. Then comes the posture, trauma, and accidents. Well, the local factors or the intrinsic factors, the anomalies of the number like supernumerary teeth or missing teeth, then anomalies of the tooth size like microdontia, macrodontia, etc., anomalies of the tooth shape like teeth are not properly, they don't have the morphology, especially the maxillary lateral incisors, abnormal labial frenum. I have already discussed about that. Then the premature loss of the tooth. Most commonly, the reason is caries. Then prolonged retention of the deciduous tooth, and especially the anterior dental crossbite. It develops because of prolonged retention of the deciduous maxillary incisors. So maxillary permanent incisors, which are erupting, they are trying to erupt from the more lingual and more apical position. They start developing, though the permanent teeth, like the deciduous teeth, are still present. So permanent teeth, they start erupting, and when they start erupting, they erupt in a more lingual position, leading to dental crossbite of a one tooth or maybe couple of teeth. Then the delayed eruption of permanent teeth, abnormal eruptive path, ankylosis of the teeth, dental caries, and improper dental restorations. The tooth are not properly restored. So over here, we are done with our today's lecture, which was the second part of etiology of the malocclusion. And on 19th, we will be discussing all these factors one by one in detail, so that it will be making more sense to you that how these factors, they affect. So over here, we are done with our today's lecture, and I will hand it over back to Farooq. So Farooq, yes, please.
Sir, today's lecture was very good. Thanks for this bit of information. Sir, I had a question I would ask you. Sir, if a patient has a fracture of mandible,
Yes.
so I just read in one of my book, when a patient had fracture in the mandible, then when you like then or if like a patient has a resorb tooth basically, so your mandible and your occlusion can deviate also as well.
Yes, it does.
So sir, is it truth?
Yes,
Yes
it
sir.
would be possible. First of all, trauma be can have the detrimental effects in many ways, and this is one of those.
Okay sir, thank you very much. I
You are
don't
welcome.
think so sir. Anyone has other question? Thanks a
Anyone
lot
who
sir
has
for the
any
today's
questions,
lecture.
they can always post, and they can always send it to me or you, and we can address to all of you.
Sure sir, thank you very
Thank
much
you
sir.
very much.
Khuda
Okay,
Hafiz.
Allah Hafiz.
Khuda Hafiz.